Well, thank you very much, Mr. Chairman, for that introduction. And like has been mentioned, I'm going to basically speak to you about responding appropriately to complex health needs of most at-risk populations, or what we are calling key populations here, however in hard-to-reach areas. So what we are going to talk about tonight is how we can improve HIV outcomes through integrated service delivery to fishing communities, and in this case, a set of islands that are in the biggest lake in Africa called Lake Victoria. Great enough integration has been well defined for me by my colleague, so I won't go through that again. I'm going to take it in the context that she took it when she presented the WHO definition of integration. I'm going to talk about very briefly in this presentation background and description of where we work and what we are, some illustrative results from the integration that we have tried to do over the last 3 or 4 years, and then also provide some lessons learned and some conclusions that we get out of this. The Sigulu Islands, like I mentioned, are based in Uganda. That's the region where we work, the yellow sort of area, that's where we work. That's 9 districts in East Central Uganda. That area has about 3 million people in all, but some of them live in those red areas that are highlighted over there, and the Sigulu Islands are in the blue circle. As you can see from the number of canoes and boats over there, the major commercial activity in these islands is basically commercial fishing. Fishing communities, as many people from sub-Saharan Africa know, have been noted to have a particularly high risk of acquiring HIV infection, and the Sigulu Island archipelago is no exception. It's basically a group of islands in a district called Namayingo district in Uganda that comprises of about 11 out of 19 inhabited islands, with a fluctuating population that ranges from about 40 to 50,000 people, most of whom are fishing families. Fishing is very lucrative. They actually call the lake the World Bank, because you actually go there, you get fish, and depending on what your catch is, you cash it in and get money for the day. Many nationalities are attracted. Uganda has about 45 to 50 tribes, so many nationalities come in from Uganda to these islands to fish, and sometimes also coming from the neighboring countries, in particular Kenya. And the daily access to disposable income leads to very high-risk behaviors such as transactional sex with commercial sex workers, alcoholism, and drug utilization. A baseline survey that we did in these islands in 2010 showed a very high prevalence of sexually transmitted infections. In particular, HIV prevalence, depending on which island you went to, ranged from anything from 17 to 30%. So as a project that is funded by USAID, we are called Strengthening TB and HIV/AIDS Responses in East Central Uganda, that strapline in red over there. We noted that healthcare infrastructure is very, very poor in these islands and actually low level. In other words, you don't get hospitals that can provide operations. Here you normally get clinic type of facilities, and even those are very dilapidated, like you can see in that photograph over there. And essentially access to these islands can actually take you up to 8 hours by some of the boats that I showed you in an earlier picture. Even motorized boats take a long time to actually move in between the islands and also from the mainland to the islands. And as I mentioned earlier, due to the migrant nature of the islanders, they basically have very poor health-seeking behavior. Today they will be on island X, and when the fish migrate to another set of islands, they tend to follow the fish, and therefore they are very, very hard actually to provide health care if they have chronic conditions. So STAR-EC, which I mentioned, is Strengthening TB and HIV/AIDS Responses in East Central Uganda, which is a USAID-funded project that is managed by JSI Research and Training Institute, Inc., conducts quarterly outreaches to these islands, and we provide integrated service delivery, as was mentioned in the previous presentation. However, due to the very poor infrastructure that is at these islands, we tend to improvise and use tents instead of using permanent structures. We provide a range of services as part of the integration, services including HIV testing and counseling, voluntary male medical circumcision, STI management, family planning, malaria, HIV treatment, risk reduction initiatives, antiretroviral therapy, as well as dissemination of IEC materials. STAR-EC is essentially a TB and HIV/AIDS project, but we link up with other service providers, notably the district health workers and other civil society organizations that work within the districts that we work in, and then they can provide other auxiliary services like the malaria diagnosis and treatment, like the immunization, family planning, and others that we may not be able to provide. But basically, in terms of those who have HIV, and we diagnose them as HIV positive, we tend to provide what we call a continuum of response, as I'm going to explain in subsequent slides, in order to emphasize linkages to care for these individuals. That's a rather crowded slide, but essentially it's to show you what we do. When we reach an island and there's no infrastructure, we tend to set up tents, and each tent has some specific activities that we carry out or conduct depending on the nature of what we have come to do. So some tents are for registration, as you can see. Others are for provision or registration for HIV testing and counseling. We provide voluntary medical male circumcision in other tents, general health care in others. If there is a physical structure like a health facility, then we provide refills for ART. We do ART initiation. We provide chronic care. We do postnatal and antenatal care, including family planning. As you can see, we provide pills, Depo-Provera implants, very occasionally vasectomy. General laboratory services are also provided if there is a general lab that we can be able to use there to provide services like CD4, counting and, diagnosis of STIs, malaria diagnosis, and so on and so forth. So we basically lay out a number of tents out there and provide services as far as we can improvise. That's just to emphasize what I've mentioned in the previous slide pictorially, and you can see that the limited infrastructure calls for improvisation. Sometimes the labs are mobile and actually in fields, but they serve our purposes and we can be able to carry out the diagnosis or the diagnosis that we want to carry out. Sometimes as we are moving on the boats, we do the CD4 counting and the hematocrit counts and other blood counts as we are moving and going on to these islands. Now, in terms of the illustrative results that we have actually got from the work that we do here, between April 2011 and June 2014, we have gone a number of times to these islands, mostly quarterly, sometimes twice every 4 months. And as you can see, we provided HIV testing and counseling for almost 23,000 individuals. 11% overall were positive, and we enrolled 45% of those who were positive, depending on the criteria for Uganda enrollments on ART over, by then it was a CD4 count of less than 300 cells. We enrolled 45% on ART. We also provided the continuum of response that I talked about, and 77% of all HIV patients were linked to care. That's not 100% because I said that many of these populations are mobile, and you may look for them the next time you go back and they are nowhere to be seen. They have actually immigrated to islands elsewhere or even to the mainland. We managed, however, to circumcise 100% we managed to test for HIV of all the people that we managed to circumcise, and we also managed to link the pregnant women, 100% of all those who were diagnosed to be HIV positive, to PMTCT. Women in Uganda do not fish, so they are not as mobile as their partners or husbands. And therefore it's easier to get them and link them to the services that we provide them to. We also managed to put 100% of all TB cases that we diagnosed on treatment. Those were 82 patients. We provided other services. STI prevalence is high, like I mentioned, and therefore almost 1,500 clients received STI treatment. We also provided family planning. Uptake here, unfortunately, is quite low. We have only managed to get one man to actually do a vasectomy. Not very many women to actually have implants or long-term permanent methods of family planning. Most of them actually prefer Depo-Provera, and not very many prefer pills because of the various, thoughts and perceptions about family planning. Condom utilization is rather high. We have managed to distribute over 600,000 pieces of condoms. both male and female pieces to this population, which helps. So what have we seen essentially that has been happening during the time that we have been there between 2011 and 2014? If you look at that graph, you notice that we are trying to compare what we see in East Central Uganda, that's the mainland, the 9 districts that we work in, to those 11 islands where we normally work. HIV prevalence was quite high at baseline, 30% in the islands, only 5% at baseline in the mainland. That has pretty much remained quite low. Actually, we are now seeing 2.2% in the last quarter that ended June last month, whereas in the islands, you've seen a fall in HIV prevalence, but it's still higher. So what this tells us is actually that the Sigulu Island chain is a key driver of the epidemic in East Central Uganda and contributes a lot of the HIV positive cases, much as they only have a population of only 50,000 people compared to more than 3 million on the mainland. They actually significantly impact the HIV prevalence in this region. And that is also augmented by the fact that they're highly mobile. The commercial sex workers come to the island, spend a couple of months, and then get known, and then move on back to the mainland, and a new set comes. So these populations are constantly interacting between the island and the mainland, and therefore they are responsible for the spread of HIV in this part of Uganda. Uptake of services in the islands has been commendable. That's an illustration of VMMC. We have noticed that uptake has steadily increased. We have circumcised just over 5,000 men to date for HIV prevention, and that represents about 40% of the eligible population between the ages of 10 and above. Most of the fishermen in this particular part of the country are, of course, young because it's quite energetic to try and fish, and therefore it's between men, it's mainly men between 15 and 40 years of age who do the fishing, and good enough, many of them have taken up circumcision, and this is not a traditionally circumcising group of people. What lessons have we learned out of the work that we have done? We have learned that an integrated outreach model has increased access to and uptake of services in a very hard-to-reach area, which has high HIV prevalence. We have also learned that despite poor infrastructure, improvisation does allow delivery of much-needed services, like we have been able to do using tents and open spaces. And we have also learned that directing resources to where new HIV infections are likely to emerge contributes to controlling the spread of the epidemic. In this case, we have a small population, but highly significant in terms of HIV spread in East Central Uganda. And therefore, we believe that combating HIV in the Sigulu Island chain through multiple approaches will contribute markedly to controlling HIV in East Central Uganda, in addition to providing all the other much-needed services, because overall service provision in this part of the country is actually poor. I would like to acknowledge all those for, having provided support and assistance in the work that we did here. Thank you very much.